welcome to the deep dive. When most of us hear mono, we probably picture a few miserable weeks in high school or college, maybe a really bad sore throat and feeling completely drained. But what if I told you the virus behind it, Epstein-Barr virus, or EBV, is far more insidious? It's silently involved in a surprising number of serious conditions, from certain cancers to rare, debilitating immune disorders. Today, we're not just skimming the surface, we're taking a truly comprehensive deep dive into EBV, equipping you with the knowledge medical professionals rely on.
It's truly astounding how pervasive EBV is, lurking asymptomatically in over 90% of adults worldwide. But here's the truly eye-opening part. Its impacts swing wildly from utterly silent to life-threatening. Our mission is to dissect its journey through the body, its varied manifestations, and its most intricate clinical associations. We're going to help you understand this virus with the kind of depth that distinguishes an informed observer from a genuine expert.
Exactly. Our goal isn't just to inform you, but to help you master this information. We'll cover everything in detail, from its basic definition, how it spreads, its intricate dance within your cells, to its most severe clinical associations and the precise diagnostic methods used to identify it. Prepare to gain a truly comprehensive understanding of this elusive and surprisingly complex virus. So let's start with the basics, or perhaps what we thought were the basics. Our sources make it clear that EBV is the culprit behind what doctors formally call heterophile-positive infectious mononucleosis.
That's quite a mouthful.
It is. That's the official technical term for what everyone else simply calls mono. It's a classic cluster of symptoms: a persistent fever, a very sore throat, noticeably swollen lymph nodes, especially in the neck, and a specific finding in blood tests, an increase in what are termed atypical lymphocytes.
Right, those distinctive-looking white blood cells.
Exactly. These are the telltale signs that often send someone to the doctor thinking they've got, severe flu or something.
What's crucial to understand, though, is that EBV is much more than just a typical virus causing a self-limited illness. It belongs to the herpesvirus family, a notorious group that also includes the viruses responsible for cold sores and chickenpox.
Ah, okay. So that family connection is important.
It's key. This family trait means EBV has the remarkable ability to establish lifelong latent infections within the body. Once you're infected, the virus pretty much stays with you for good, often lying dormant, only to reactivate under certain conditions.
So it's not a catch it and get over its kind of bug. It sets up a permanent residence.
Precisely. It becomes a lifelong companion, whether you know it or not. This leads to a critical question. Why does this particular herpes virus have such incredibly diverse and often very severe impacts, far beyond a typical case of mono? Our sources highlight its astonishing association with a wide spectrum of tumors.
Tumors, really, from mono.
Well, from the virus that causes mono. We're talking about conditions like nasopharyngeal carcinoma, which is a cancer of the upper part of the throat behind the nose. Also gastric carcinoma, or stomach cancer, and several types of lymphoma, including Burkitt's lymphoma, Hodgkin's lymphoma, T-cell lymphoma, and even B-cell lymphoma.
Wow. That's quite a list.
It is. And what's particularly alarming is its link to smooth muscle tumors, especially in individuals with compromised immune systems. This extensive and often deadly list truly underscores that EBV is anything but a benign pathogen for everyone. It has this dark, insidious side.
What genuinely surprised me in the research was discovering that there are actually two types of EBV widely prevalent in nature.
Two types?
Yeah, two types. Yet our standard serologic blood tests can't even tell them apart.
That is interesting. So the tests just show infection, not the specific type.
Exactly. Imagine that this incredibly common virus has a hidden layer of complexity we barely detect through routine diagnostics. It really highlights how much more there is to learn about even the most common pathogens that infect us. Hashtag #TagTech2, the global footprint and clever transmission of EBV. So we know EBV is pervasive, infecting most adults, but how exactly does this widespread virus manage to get around so effectively? Our sources confirm that EBV infections occur worldwide, which makes perfect sense given those high infection rates. But here's where it gets nuanced. The way it manifests, particularly as infectious mononucleosis, or IMM, really depends on where you are in the world and your socioeconomic background.
Right. It adds an intriguing epidemiological layer to its story. Indeed, the epidemiology tells a fascinating tale. In lower socioeconomic groups or regions with, shall we say, less rigorous hygiene standards, like many developing countries, EBV tends to infect children at a very early age.
Okay, early infection. And what happens then?
The surprising part is that in these populations, IM symptomatic mono is actually quite uncommon. It often remains asymptomatic or presents very mildly.
Huh. So getting it early means you're less likely to get sick from it.
It appears so. Now, contrast that with areas having higher hygiene standards, like many developed countries, where infection is often delayed until adolescence or young adulthood. And that's precisely when IM becomes significantly more prevalent.
So later exposure means a higher chance of getting the classic monosymptoms.
Exactly. This suggests a crucial interaction. Early exposure, when the immune system might be developing differently or less intensely, seems to lead to a milder disease experience compared to encountering it for the first time as a young adult. It's as if the immune system reacts more vigorously to a primary infection later in life.
That's a huge insight. So for those of us who grew up in cleaner environments, we might actually be more susceptible to symptomatic mono later on.
It seems counterintuitive, but yes, that's what the pattern suggests.
Now, the most common way it spreads, as our sources confirm, is through direct contact with oral secretions.
Saliva, essentially.
We're talking saliva here. It's frequently transmitted from asymptomatic adults to infants, perhaps through shared utensils or even, pre-chewed food in some cultures, and famously or infamously among young adults during kissing.
Ah, yes, the kissing disease.
Hence the incredibly apt kissing disease nickname. The research notes that transmission by less intimate contact is rare, making direct salivary exchange the dominant route, which explains its efficient spread among close contacts.
A critical question arises then. Beyond the kissing disease route, are there other, less common but important transmission pathways?
Good question. What else is there?
Well, while direct salivary transfer is primary, the virus can also be transmitted via blood transfusion and bone marrow transplantation.
Ah, okay, so that's important for hospitals and blood banks.
Absolutely.
Right.
This is a vital consideration for medical professionals, especially in settings where patients are already severely immunocompromised. What's even more crucial for understanding its global prevalence is the virus's persistence. More than 90% of individuals who are seropositive, meaning they've been infected at some point, will continuously shed the virus in their oropharyngeal secretions.
Even if they feel perfectly fine.
Exactly. Even if they show absolutely no symptoms themselves, they become silent carriers.
Wow, 90% are shedding it.
And this viral shedding increases significantly in immunocompromised patients and those with acute IM, effectively making them more efficient transmitters. This continuous shedding is a major reason why EBV is so pervasive across human populations.
Let's really peel back the layers now and understand the pathogenesis, or the way this virus causes disease within the body. Once EBV enters through those salivary secretions, where does it set up its initial foothold?
Our sources explain it first infects the epithelial cells of the oropharynx, that's the middle part of your throat behind the mouth, and also the salivary glands.
Okay, the lining of the throat and salivary glands.
Correct. And significantly, it's shed from these very cells, creating a cycle that allows for ongoing transmission.
Right, that shedding we just talked about.
What's truly fascinating is the virus's subsequent journey once it gets inside. While B cells, a crucial type of white blood cell, can certainly become infected after contact with those initial epithelial cells, studies suggest that lymphocytes in the tonsillar crypts, those small pockets in your tonsils, can be infected directly.
Directly into the immune cells in the tonsils.
It seems so. From there, the virus spreads widely through the bloodstream, essentially sowing seeds of infection throughout the body. The hallmark of infectious mononucleosis, that significant enlargement of lymphoid tissue throughout the body, is primarily due to the rapid proliferation and expansion of these EBV-infected B cells.
So the swollen glands are basically masses of infected B cells multiplying.
Largely, yes. But it's not just the B cells acting alone. There's a strong reactive T cell response that also contributes massively to this lymphoid tissue swelling. This widespread B cell infection also triggers what's called a polyclonal activation of B cells.
Polyclonal activation. What does that mean?
It just means a widespread immune system alert where many different types of B cells get activated, leading to the production of a wide variety of antibodies. These antibodies target both our own host proteins, sometimes leading to autoimmune issues, and the viral proteins themselves. It's a very broad and vigorous immune system alert.
So let's put some numbers to this viral invasion, because it's pretty staggering. During the acute phase of IM, an astonishing 1 in every 100 B cells in your peripheral blood can be infected by EBV.
1% of all your B cells? That's huge.
Think about that. That's a massive viral load directly targeting a key part of your immune system.
Right.
After recovery, that number drops dramatically, usually to about 1 to 50 infected B cells in every 1 million.
Still there, though, just at much lower levels.
Right, so the virus doesn't disappear. It persists, always lurking in tiny numbers. And this is where your immune system steps up in a truly impressive, almost theatrical way. During IM, there's what's called an inverted CD4 plus CD8 plus T-cell ratio.
Ah, the T-cell ratio flips.
Exactly. Essentially, the percentage of helper CD4 plus T-cells decreases, while you see huge clonal expansions of killer CD8 plus T-cells. Up to 40% of all your CD8 plus T-cells during acute infection are specifically directed against EBV antigens.
40%. That's an enormous commitment of the immune system.
This is your body bringing out the absolute biggest guns, generating a massive, highly specialized army of killer T-cells designed to eliminate the infected cells. It's a full-scale cellular war.
A crucial question, then, is where does the virus hide long-term after that acute phase, becoming a lifelong companion?
Where does it go?
The answer lies in memory B cells, not epithelial cells. These memory B cells are the primary reservoir for EBV in the body.
Memory B cells, the ones that remember past infections.
Precisely. This is a critical point because even when patients are treated with an antiviral medication like acyclovir, which effectively stops the shedding of the virus from the oropharynx, the virus still persists stubbornly within these memory B cells. The antiviral tackles the active replication, but not the latent reservoir.
So acyclovir doesn't cure it, it just dampens the shedding.
Correct. Understanding how the virus actually enters cells is also key to its pathogenesis. EBV primarily utilizes the CD21 receptor found on the surface of B cells. Interestingly, this receptor also binds to a component of our immune system called C3rd, showcasing the virus's clever exploitation of host machinery.
Well, it uses our own immune system parts to get in.
It does. There's also another B cell receptor, CD35, that interacts with CD21, and human leukocyte antigen class II serves as a co-receptor, facilitating efficient entry into B cells. For epithelial cells, it's a different story. The virus binds to a protein called ephrin A2, which then leads to robust viral replication and the production of new infectious virus particles ready to spread.
It's pretty wild to consider, but our sources mention that when B cells are infected by EBV in a lab dish in vitro, they actually become transformed.
Transformed, as in cancerous.
Well, they can proliferate indefinitely. This characteristic is a huge clue, hinting at the virus's potential to drive cancerous growth. During this latent infection in B cells, the virus expresses several unique proteins and RNAs.
Things like eBNAs and LMPs.
Yes, exactly. EBV nuclear antigens, eBNAs, latent membrane proteins, or LMPs, along with multiple microRNAs and small EBV RNAs known as EBRs. These viral components essentially allow the virus to persist, hide from the immune system, and subtly manipulate the host cell.
So it's actively managing its presence within the cell.
Right. While these transformed B cells do secrete immunoglobulin, demonstrating they retain some B cell function, only a small fraction of them actually produce more infectious virus.
Ah, so they're mostly staying latent, not actively replicating in large numbers.
It seems like a clever balance, maintaining a low profile while ensuring its long-term survival within the host.
When we connect this to the broader picture of immune control, it becomes clear that cellular immunity, particularly the role of T cells, is far more important than humoral immunity, which is the antibody-mediated response in controlling EBV infection.
T cells are the main defenders here.
Absolutely. In that initial acute phase, a trio of immune cell suppressor T cells, natural killer or NK cells, and nonspecific cytotoxic T cells are critical for reining in the rapid proliferation of those EBV-infected B cells. During this early, vigorous immune response, we see elevated markers of T-cell activation and high levels of serum interferon gamma, all signaling a strong, coordinated cellular defense.
So the body throws everything at it early on.
It does. Later in the infection, the immune system refines its attack, generating highly specific cytotoxic T cells. These are essentially precision missiles. They recognize specific viral proteins like eBNAs and LMPs, which are presented on the surface of infected cells, and they are designed to seek out and destroy those EBV-infected cells, eliminating the viral factories. It's a highly targeted, efficient defense mechanism.
A targeted strike force.
Precisely. This raises a crucial question. What happens if this finely tuned T-cell immunity is compromised?
That sounds like trouble.
It is. That's when those EBV-infected B cells can begin to proliferate unchecked, leading to serious, often life-threatening diseases. And for immunocompetent individuals where EBV is linked to certain lymphomas, the virus-induced proliferation isn't a direct cause, but rather just one step in a complex, multi-step process toward neoplastic transformation.
So it pushes cells towards cancer, but doesn't necessarily cause it single-handedly.
Exactly. It's essentially pushing cells further along the path to becoming cancerous. Here's a truly insidious detail. In many EBV-containing tumors, a specific viral protein called LMP1 actually mimics members of the tumor necrosis factor receptor family, like CD40.
It mimics our own signaling proteins.
Yes, think of it as a viral imposter that effectively transmits continuous growth-proliferating signals to the cells. This mimicry acts as a crucial driver, continuously nudging those cells further along the path to cancer.
It is incredibly sophisticated and sneaky.
It illustrates the profound and often subtle ways this virus can manipulate host cell pathways for its own survival and replication.
So we've explored the virus's internal mechanisms. Now, how does all this complex viral activity actually show up in the body? The clinical manifestations of EBV infection are surprisingly varied, and age plays a huge role in how it presents.
That age factor is really key, isn't it?
It really is. Our sources tell us that most EBV infections in infants and young children are either completely asymptomatic, meaning no symptoms at all, or they just look like a mild sore throat, perhaps with some tonsillitis.
So kids often just shrug it off.
Pretty much. But here's where it gets really interesting. About 75% of infections in adolescents present as full-blown infectious mononucleosis, with all the classic debilitating symptoms we associate with mono.
75%, that's the majority of teens getting symptomatic mono.
Right, and for the elderly, it's often very non-specific things like prolonged fever, pervasive fatigue, muscle aches, and a general feeling of malaise, without the classic sore throat or swollen lymph nodes.
That sounds really hard to diagnose in older adults.
Absolutely. This non-specificity can make it quite a diagnostic challenge for clinicians, often mimicking other less traumatic conditions.
You're right, the presentation can be quite different depending on age. For young adults, the incubation period for IM is typically about 4 to 6 weeks.
4 to 6 weeks. That's a long incubation.
It is. Before the classic trio of fever, sore throat, and lymphadenopathy fully set in, many individuals experience what's called a prodrome, a set of initial nonspecific symptoms like fatigue, malaise, and muscle aches that can last for 1 to 2 weeks.
So you feel kind of lousy before you get really sick.
Exactly. The fever is usually low grade and most common during the first 2 weeks of the illness, but in some cases, it can stubbornly persist for over a month, really prolonging that feeling of being unwell. Our sources provide an excellent overview of the common signs and symptoms. Patients frequently report sore throat, widespread malaise, headaches, various abdominal issues like pain or nausea, and chills.
Sounds miserable.
It certainly can be. Meanwhile, objective signs that medical professionals actively look for during an examination include lymphadenopathy, or those swollen lymph nodes, fever, pharyngitis, or tonsillitis, and splenomegaly, which is an enlarged spleen. All of these are frequently observed in classic IM.
The enlarged spleen. That sounds concerning.
It is something doctors watch carefully. A crucial question for clinicians is how these symptoms progress over time. Lymphadenopathy and pharyngitis are typically most prominent during the first 2 weeks of the illness. Those swollen lymph nodes are often tender to the touch and symmetrical, meaning they're enlarged on both sides, and they're usually found in the posterior neck at the back of your neck.
Okay, back of the neck, tender, both sides. Got it.
The pharyngitis, or sore throat, can be incredibly severe, with tonsils so enlarged they may have a white, pus-like coating and exudate strikingly resembling strep throat, which often leads to misdiagnosis.
Yeah, I can see how you'd mistake that for strep.
Absolutely. Splenomegaly, the enlarged spleen, tends to become more prominent in the 2nd and 3rd weeks of the illness, which is why strict physical activity restrictions are often put in place during this period, given the risk of splenic rupture.
Right, that enlarged spleen brings up a critical point. We'll get to that in a moment. But first, let's talk about skin. A morbilliform or papular rash, which looks like small, flat, or slightly raised red spots, usually on the arms or trunk, develops in about 5% of cases.
Only 5%, so not that common.
No. And our sources have a really interesting note here. Earlier studies famously linked these rashes to penicillin derivatives. The idea being, if you took amoxicillin or other similar antibiotics while unknowingly having mono, you'd get this distinct rash.
I remember hearing that.
Right. But more recent research suggests this rash may occur with similar frequency whether or not someone took those drugs. And crucially, it's not predictive of future penicillin allergies.
Ah, so that connection might not be as strong as we thought. Good to know.
That's a good aha moment for anyone who heard that old wives' tale. Other less common skin conditions like erythema nodosum, which causes tender red nodules under the skin, and erythema multiforme, a target-like rash, have also been described in association with EBV, showing its wide-ranging impact on the body.
It really can affect multiple
And
systems.
speaking of impact, our sources also tell us that the actual severity of the disease correlates with the levels of those highly active CD8 plus T cells and the amount of EBV DNA in the blood.
So a stronger immune reaction might actually mean feeling worse.
It seems so. Essentially, the more viral DNA present and the more your killer T cells are ramped up to fight it, the worse you might actually feel. Most patients have symptoms for a typical duration of 2 to 4 weeks, which is the common recovery period.
2 to 4 weeks still feels like a long time when you're sick.
Oh, absolutely. However, a significant portion, nearly 10%, can experience truly debilitating fatigue for 6 months or even longer.
6 months, wow, that's long haul fatigue.
Exactly. Highlighting the protracted and challenging recovery for some individuals where the virus's shadow lingers long after the acute symptoms fade.
From a laboratory perspective, the complete blood count usually reveals an elevated white blood cell count, often peaking at 10,000 to 20,000 per microliter during the second or third week of illness. A cornerstone diagnostic feature is lymphocytosis, specifically with more than 10% typical lymphocytes.
Those special lymphocytes we mentioned earlier.
Right. These cells are quite distinctive under a microscope. They're enlarged lymphocytes with abundant cytoplasm, sometimes with vacuoles, and characteristic indentations of the cell membrane. And importantly, those powerful CD8 plus T cells we discussed earlier predominantly make up these atypical lymphocytes, directly reinforcing their critical role in the immune response.
So the blood test literally shows the CD8 army mobilizing.
In a way, yes. Beyond that, low-grade neutropenia, a decrease in neutrophils, and thrombocytopenia, a decrease in platelets, are also common during the first month. And the liver, almost invariably, takes a hit. Abnormal liver function is seen in over 90% of cases, typically manifesting as mild elevations in aminotransferases and alkaline phosphatase.
Liver enzymes go up.
Yeah, and serum bilirubin, another liver function marker, can be elevated in about 40% of cases, occasionally leading to a mild, noticeable jaundice.
While the vast majority of IM cases are self-limited, meaning they resolve on their own without specific treatment, and deaths are thankfully extremely rare.
That's reassuring.
It is. But our sources do outline some very serious, albeit uncommon, complications. When fatalities do occur, they are most often tragically due to severe central nervous system complications, splenic rupture, upper airway obstruction, or bacterial superinfection.
Okay, those sound really serious. Splenic rupture.
Yes. These are the critical watchouts that medical professionals meticulously monitor for when managing severe cases of mono, as they can indeed be life-threatening and require immediate intervention.
Let's delve into those rare but serious complications, starting with the neurological ones. Central nervous system complications typically develop within the first 2 weeks of infection. What's especially tricky is that sometimes, particularly in children, these can be the only clinical manifestations of an acute EBV infection.
The only sign, no fever, no sore throat.
Sometimes, yes, making diagnosis incredibly challenging as the classic heterophile antibodies and atypical lymphocytes may be completely absent.
Wow. So what kind of neuro problems are we talking about?
Meningitis and inflammation of the membranes surrounding the brain and spinal cord, and encephalitis, inflammation of the brain itself, are the most common neurological issues. Patients may present with a severe headache, meningismus, which is neck stiffness similar to meningitis, or cerebellar ataxia, affecting balance and coordination.
Ataxia, problems walking.
Yes, balance issues. Acute hemiplegia or weakness paralysis on one side of the body, and even psychosis have been described. If cerebrospinal fluid is analyzed, it usually shows an increase in lymphocytes, sometimes atypical ones.
Is there lasting damage?
The good news is that most cases of these neurological complications resolve without lasting neurological issues. But EBV infection has also been linked to a surprising array of other conditions. Cranial nerve palsies, particularly of the facial nerve.
Like Bell's palsy.
Similar, yes, causing facial weakness or paralysis. Guillain-Barré syndrome, a rapid onset muscle weakness caused by the immune system damaging the peripheral nervous system. Acute transverse myelitis, an inflammation of the spinal cord. And peripheral neuritis, inflammation of peripheral nerves. This raises a crucial question that still puzzles researchers. Why would a virus primarily known for affecting lymphoid tissue also impact the nervous system so profoundly, given its primary tropism for B cells and epithelial
Yeah,
cells?
how does it get to the nerves?
It suggests a broader, perhaps indirect, mechanism of action on neural tissue, still an area of active research.
And here's where it gets really intriguing on the immune front. Autoimmune hemolytic anemia occurs in about 2% of cases, typically during the first 2 weeks of illness.
Autoimmune, attacking your own red blood cells.
Exactly. This is usually a Coombs-positive anemia with what are called cold agglutinins. In simpler terms, your body's immune system, in a strange twist, produces antibodies that attack its own red blood cells, especially at lower temperatures.
That sounds dangerous.
Most patients who experience this have mild anemia that resolves in a month or two. But some can have severe disease with hemoglobinuria, meaning red blood cells in the urine, and jaundice, a yellowing of the skin. It's a clear example of the body's immune system, in a way, turning on itself.
A real case of friendly fire from the immune system.
You could say that. Nonspecific antibody responses can also pop up more generally, like rheumatoid factor, anti-nuclear antibodies, anti-smooth muscle antibodies, anti-platelet antibodies, and cryoglobulins, all pointing to a general immune dysregulation triggered by the infection. Our sources also list red cell aplasia, where the bone marrow fails to produce red blood cells, severe granulocytopenia and thrombocytopenia, which are severe drops in specific white blood cells and platelets, respectively, pancytopenia, a dangerous decrease in all blood cell types.
Pancytopenia, that affects everything.
Yes, and hemophagocytic lymphohistiocytosis, a severe, life-threatening immune overactivation. These are all rare but severe hematologic complications.
Let's return to that critical complication, splenic rupture. While thankfully very rare, occurring in less than 1.5% of cases, it is a life-threatening emergency, and it's more common in male patients.
Less than 0.5%, but still devastating when it happens.
Absolutely. It can manifest as sudden, excruciating abdominal pain, referred shoulder pain if the diaphragm is irritated, or even signs of hemodynamic compromise, which indicates a dangerous drop in blood pressure and insufficient blood flow to organs. This requires immediate medical attention.
Okay, so that spleen enlargement is no joke.
Not at all. This is precisely why avoiding excessive physical activity, especially contact sports or heavy lifting, for at least the first month of illness is a key non-negotiable recommendation for patients diagnosed with IM. Another potentially life-threatening complication is upper airway obstruction.
From swollen tonsils.
Yes, this can result from hypertrophied tonsils or adenoids becoming excessively large, or from severe inflammation and edema swelling of the epiglottis, pharynx, or uvula. This occurs in about 10% of IM patients and can be very serious, sometimes requiring urgent intervention to maintain an open airway.
10%. That's actually quite a few people needing help breathing.
It is a significant concern in severe cases. Furthermore, our sources list other rare but significant complications that underscore the virus's systemic reach. These include fulminant hepatitis, which is severe, rapidly progressing liver inflammation, myocarditis or pericarditis, which are inflammations of the heart muscle or the sac surrounding the heart, respectively.
Heart inflammation, too.
Yes. Also, pneumonia with pleural effusion, where fluid builds up around the lungs, interstitial nephritis, kidney inflammation, painful genital ulcerations, and vasculitis, and inflammation of blood vessels throughout the body.
It really can hit almost anywhere.
This extensive list truly shows the widespread potential impact of EBV, affecting nearly every organ system in rare but profoundly significant instances.
Now, this is where EBV's story truly takes a complex and often much darker turn. It's not just about mono. Our sources detail several other distinct diseases where EBV plays a central, often causative role, especially when the immune system is struggling.
Right, when the brakes are off the immune system, EBV can really cause problems.
Exactly. These are conditions that really underscore the virus's insidious capabilities and its capacity to contribute to far more serious illnesses.
What's particularly eye-opening here is EBV-associated lymphoproliferative disease, or LPD.
LPD, what's that?
This is primarily seen in patients with either congenital, meaning inherited, or acquired immunodeficiency. Think individuals born with severe combined immunodeficiency, patients with AIDS, or recipients of bone marrow or solid organ transplants, especially those on powerful immunosuppressive drugs like cyclosporine.
So people with very weak immune systems.
Precisely. In these cases, those EBV-infected B cells, which are normally kept in check by a healthy immune system, begin to proliferate uncontrollably, infiltrating and growing within lymph nodes and multiple organs throughout the body.
The B cells just go wild.
They do. Patients typically present with symptoms like persistent fever and generalized swollen lymph nodes, or they might experience specific gastrointestinal symptoms if the LPD affects the digestive tract. Pathological studies of the affected tissues can show anything from a reactive B-cell hyperplasia, which is an overgrowth of B cells but still relatively benign, to a full-blown poly or monoclonal lymphoma.
A lymphoma?
Think so?
Cancer.
Yes, highlighting the severe spectrum of immune dysregulation and direct potential for malignancy driven by the virus in a compromised host. It's a stark reminder of the immune system's critical role in keeping this virus in check.
Okay, let's unpack a truly rare but devastating condition. X-linked lymphoproliferative disease, or XLP.
XLP, this one's particularly tragic.
It is. This is a recessive genetic disorder that almost exclusively affects young boys because it's linked to the X chromosome. What's heartbreaking is that these boys often have a perfectly normal immune response to common childhood infections, living typical healthy lives.
Until they encounter EBV.
Exactly. But then they get infected with EBV, and instead of a self-limited case of mono, it can be fatal, leading to an overwhelming, uncontrolled immune response that essentially spirals out of control.
A critical question here is, why is EBV so lethal for these specific boys? The protein associated with most cases, called SAP, which is encoded by the SH2D1A gene, is absolutely critical because it mediates essential interactions between B and T cells.
So a breakdown in communication between immune cells.
Precisely. Without proper SAP function, the vital T cell response against EBV-infected B cells is severely compromised. This leads to uncontrolled B cell proliferation and a dangerous hyperinflammatory state. Most patients sadly die from acute fulminant infectious mononucleosis, where the immune system simply cannot rein in the virus.
That's awful.
It is. However, others can develop different severe outcomes, including hypogammaglobulinemia, where antibody levels are dangerously low, malignant B-cell lymphomas, aplastic anemia, where the bone marrow stops producing enough new blood cells, or a granulocytosis, a severe drop in certain white blood cells, making them highly vulnerable to other infections. Our sources also mentioned variants resembling XLP, but with more prominent hemophagocytosis, a condition where immune cells mistakenly engulf and destroy other blood cells linked to mutations in the BRC4 gene.
More genetic links.
Yes, and furthermore, other specific gene mutations, such as those in ITK, MET1, CORA1A, CD70, or CD27, are also associated with an inability to control EBV and a significantly increased risk of lymphoma. This broad spectrum of genetic vulnerabilities is critical for understanding severe EBV disease. And even more starkly, in some rare tragic instances, IM can prove fatal to patients with no obvious pre-existing immune abnormality, showing there are still many unknowns and individual susceptibilities at play in how we respond to this pervasive virus.
Beyond these very severe, often genetically linked conditions, EBV also shows up in other, perhaps less dramatic, but still distinct places. For instance, oral hairy leukoplakia. Those raised, white, corrugated lesions that primarily appear on the tongue are often seen in HIV-infected adults and are known to contain EBV DNA.
Right, that's a classic sign in some HIV patients.
It's a fairly common oral manifestation, a visible sign of the virus taking advantage of a weakened immune system. And in HIV-infected children, EBV DNA is often found in the lung tissue of those with lymphoid interstitial pneumonitis, another chronic condition linked to a compromised immune system, allowing the virus to contribute to lung disease.
This raises a really important question, particularly given public perception and many people's personal experiences. Is EBV a cause of chronic fatigue syndrome?
Ah, the CFS connection. That comes up a lot.
It does. Our sources are very clear on this, and it's a critical distinction. While patients with chronic fatigue syndrome may have elevated EBV antibody titers, these are not significantly different from healthy individuals who have been infected with EBV at some point in their lives.
So the antibodies don't prove causation.
Correct. Crucially, and this is the key differentiator, they do not have elevated levels of EBV DNA in their blood, which would indicate active, persistent infection and viral replication. The evidence states unequivocally that persistent, active EBV infection is not a cause of chronic fatigue syndrome.
Okay, that's a really important clarification. EBV does not cause chronic fatigue syndrome.
Exactly. This is a common misconception that needs to be clarified for anyone struggling with chronic fatigue symptoms. However, there is a distinct and very rare condition called chronic active EBV infection, and this is fundamentally different from chronic fatigue syndrome.
Okay, so there is a chronic EBV condition, just not CFS.
Correct. Affected patients have an illness lasting more than 6 months, but with truly elevated and persistent levels of EBV DNA in their blood. This viral DNA can be found specifically within T cells, NK cells, or B cells, indicating a specific cellular tropism for the persistent infection.
So the virus is actively present and replicating in specific immune cells.
Yes, they also have very high, significantly abnormal antibody titers to EBV, pointing to a dysregulated immune response. Critically, these patients also show clear evidence of specific organ involvement, such as hepatosplenomegaly, meaning enlarged liver and spleen, lymphadenopathy or swollen lymph nodes, hepatitis, pneumonitis, uveitis, and inflammation of the eye, or various neurologic diseases.
So real organ damage, unlike CFS.
Absolutely. Some patients with chronic active EBV infection even have somatic mutations in genes like DD3X and other known tumor driver genes, indicating a profound underlying genetic dysregulation that allows the virus to persist and cause severe multi-organ disease. This is a life-threatening condition, a stark contrast to chronic fatigue syndrome.
This is perhaps the most shocking and frankly chilling aspect of EBV's capabilities. Its transformation from a seemingly innocuous monovirus into a cancer-contributing agent.
Yeah, the cancer link is really where EBV shows its darker side.
Our sources highlight its association with several serious malignancies. This isn't just a benign virus that causes a mild illness for most. It's a significant player, an accomplice, in the development of certain cancers, especially when other predisposing factors are present.
When we connect this to the bigger picture of global health, it's striking. Approximately 15% of Burkitt's lymphoma cases in the United States, but a staggering 90% of those in Africa are directly associated with EBV.
90% in Africa versus 15% in the U.S. That's a huge difference.
It is. In African patients, the affected tumor tissue almost always contains viral DNA, demonstrating a very strong, almost indispensable link. This raises a crucial question. Why such a dramatic geographic difference in this association?
With the theory.
Our sources propose a fascinating and complex hypothesis. Malaria, which is highly endemic in many African regions, may actually impair cellular immunity to EBV. Additionally, malaria can induce a polyclonal B-cell activation, essentially causing a widespread, uncontrolled expansion of EBV-infected B cells.
So malaria weakens the defense against EBV and makes the target cells multiply.
Precisely. Furthermore, malaria may specifically target B cells and result in the expansion of germinal centers within lymph nodes, consequently increasing the activity of an enzyme called activation-induced cytidine deaminase, which is known to mutate DNA.
More mutations. That sounds bad in the context of cancer.
It is. These combined changes impaired immunity, D-cell expansion, and increased mutation rates can dramatically enhance the proliferation of B cells with elevated EBV DNA in the bloodstream. This significantly increases the likelihood of a c-Myc translocation.
The genetic hallmark of Burkitt's lymphoma.
Exactly. That specific genetic error, a dangerous switch, that acts as the hallmark of Burkitt's lymphoma, driving uncontrolled cell growth. It's a truly complex interplay of a viral infection, a parasitic infection, and genetic predispositions. It's also important to note that EBV-containing Burkitt's lymphoma also occurs frequently in AIDS patients, further emphasizing the crucial role of immune compromise in allowing the virus to drive malignancy.
Then there's anaplastic nasopharyngeal carcinoma, which is notably common in southern China and is almost uniformly associated with EBV.
Nasopharyngeal, cancer of the throat area again.
Right. The affected tissues consistently contain both viral DNA and antigens, clearly demonstrating the virus's direct involvement. Patients with this aggressive cancer often have significantly elevated EBV antibody titers, serving as a biological marker of the virus's strong presence. And here's a really important practical takeaway for medical management. Our sources state that measuring EBV DNA in plasma is proving to be incredibly useful for the early detection of nasopharyngeal carcinoma.
Using a blood test to find throat cancer early.
Yes, allowing for earlier intervention. Furthermore, high levels of EBV plasma DNA before treatment or any detectable levels after radiation therapy correlate directly with lower overall and relapse-free survival rates among patients.
So it's useful for prognosis and monitoring, too.
Absolutely.
Yeah.
This clearly shows how crucial these viral markers are, not just for confirming a diagnosis, but also for predicting prognosis and meticulously monitoring treatment effectiveness. It's a powerful tool in oncology.
Globally, the most common EBV-associated malignancy is actually gastric carcinoma, or stomach cancer.
Stomach cancer. We didn't know EBV was linked to that.
Yes, with about 9% of these tumors being EBV positive. This includes over 90% of gastric lymphoepithelioma-like carcinomas, a specific subtype of stomach cancer. EBV has also been strongly associated with Hodgkin's lymphoma, particularly the mixed cellularity type.
Another lymphoma connection.
Right. About half of U.S. cases of Hodgkin's lymphoma show viral DNA and antigens within the characteristic Reed-Sternberg cells, which are the hallmark malignant cells of this cancer. The risk of developing EBV-positive Hodgkin's lymphoma is significantly increased in young adults for several years after experiencing EBV seropositive infectious mononucleosis.
So having mono actually increases your risk later.
For this specific type of lymphoma, yes, the data suggests that. Furthermore, about 50% of non-Hodgkin's lymphomas in patients with AIDS are EBV positive, again emphasizing the profound role of immune suppression. Our sources also mention EBV in B cells of lesions from patients with lymphomatoid granulomatosis, a rare immune disorder. And viral DNA has been detected in tumors from immunocompetent patients with angiocentric nasal NK T-cell lymphoma, aggressive NK leukemia lymphoma, T-cell lymphoma, and CNS lymphoma.
Wow, it's linked to T-cell and NK cell cancers too, not just B cells.
Indeed. Demonstrating its breadth across various immune cell cancers. Even leiomyosarcomas, which are cancers of smooth muscle in AIDS patients, and smooth muscle tumors in organ transplant recipients have shown viral DNA. And virtually all CNS lymphomas or brain lymphomas in AIDS patients are associated with EBV.
That is a truly staggering list that redefines our understanding of this virus. It's far more than just mono.
It really is. This leads to a profound question for ongoing research, one that could reshape our understanding of autoimmune disease. Studies have found that a history of infectious mononucleosis and higher levels of antibodies to EBNA Epstein-Barr nuclear antigen before disease onset are more common in persons with multiple sclerosis than in the general population.
EBV and MS fact.
Is there a connection? This intriguing and consistent correlation strongly suggests a possible causal relationship between EBV infection and the development of multiple sclerosis, which is a very active and critical area of scientific inquiry.
If that's proven.
Wow, if proven, it could completely change how we think about and potentially prevent this complex autoimmune disease.
Given how varied EBV can be in its manifestations, from completely asymptomatic infection to life-threatening cancers, how do doctors actually figure out if someone has an EBV infection, especially in its acute phase like mono? Our sources delve into the details of serologic testing, which is basically looking for the presence of antibodies in the blood phase ward, your immune system's unique fingerprints of past or current infection.
Right, the antibody tests are usually the first step. The classic heterophile test is the long-standing initial go-to for diagnosing infectious mononucleosis in children and adults. What's quite fascinating here is the underlying mechanism. In this test, human serum is first carefully absorbed with guinea pig kidney tissue to remove certain nonspecific antibodies that might interfere. Then, the heterophile titer is defined as the greatest serum dilution that causes the agglutination, or clumping together, of sheep, horse, or cow red blood cells.
So it's looking for an antibody that clumps animal red blood cells.
Essentially, yes. Crucially, this heterophile antibody does not directly interact with EBV proteins, but its presence is a very well-established diagnostic marker of acute EBV infection.
So it's an indirect marker.
It is. A titer of 40 or greater, when found alongside compatible symptoms of IM and the telltale presence of atypical lymphocytes in the blood, is generally considered diagnostic of acute EBV infection.
Okay, titer over 40 plus symptoms and atypical lymphs.
That's the classic picture. It's vital to understand the timing and limitations of this test, though. The heterophile test is positive in only about 40% of patients during the very first week of illness.
So it can be falsely negative early on.
Yes, meaning a negative result early on doesn't rule out mono. However, its sensitivity significantly increases to 80% to 90% by the third week of illness.
So waiting a bit might be necessary for an accurate result.
Sometimes, yes. Repeat testing might be necessary, especially if the initial test is performed too early in the disease course. These antibodies usually stay positive for about 3 months after the onset of illness, but they can, in some individuals, persist for up to a year.
Okay. Are there groups where it's less reliable?
Yes. The test is often not detectable in children under 5 years of age, in the elderly, or in patients who present with very atypical IM symptoms, making it less reliable in these specific populations. The commercially available monospot test, a rapid version of the heterophile test, is a bit more sensitive than the classic laboratory test, being approximately 75% sensitive and 90% specific when compared to more precise EBV-specific serologies.
The monospot. That's the quick one they often do in the doctor's office.
Right, but it's not perfect and can have false positives in people with connective tissue diseases, lymphomas, viral hepatitis, and malaria, so clinical context is always paramount.
So if that initial heterophile test isn't definitive, or if the infection presents atypically, what's the next more precise step in diagnosis?
That's when EBV-specific antibody testing comes into play.
Testing for antibodies against the virus itself.
Exactly. These tests are far more precise because they directly look for antibodies against specific components of the virus itself, giving clinicians a much clearer, more granular picture of the infection status, whether it's acute, past, or reactivated.
So which specific antibodies are most useful?
You've hit on a crucial distinction. The IgM antibody to viral capsid antigen, or VCA, is considered the most useful marker for diagnosing acute infectious mononucleosis.
IgM for acute infection. Why?
Because it's present at elevated titers only during the first 2 to 3 months of the disease and is typically detectable right at the onset of symptoms, making it an excellent indicator of a current infection.
Okay, IgM means happening now.
Pretty much. In stark contrast, the IgG antibody to VCA isn't useful for diagnosing acute IM because it often persists for life.
IgG means had it in the past.
Right. Instead, it's widely used to assess past exposure to EBV, indicating someone has been infected at some point. Seroconversion to eBNA positivity, meaning antibodies to Epstein-Barr nuclear antigen becoming detectable, is also useful for confirming acute infection with EBV. But these antibodies appear relatively late in the course of illness, typically 3 to 6 weeks after symptom onset.
So eBNA shows up later than VCA IgM.
Correct. Like IgG-VCA, they then persist for the lifetime of the patient. They can, however, be absent in immunodeficient patients or those with chronic active EBV disease, adding another layer of diagnostic complexity.
Are there other antibodies they look for?
Our sources also mention other antibodies, though they are generally less useful for routine diagnosis of acute IM, finding their utility in specific complex scenarios. Antibodies to early antigens, which indicate active viral replication, are detectable 3 to 4 weeks into IM. About 70% of IM patients, especially those with severe disease, have antibodies to early antigen diffuse, or EAD, during their illness. These usually only persist for 3 to 6 months.
But they can be high in other conditions.
Yes. Importantly, their levels are often elevated in patients with nasopharyngeal carcinoma or chronic active EBV infection, making them useful markers in those specific, more serious contexts. Antibodies to early antigen-restricted, or EAR, are often found at high titers in patients with African Burkitt's lymphoma or chronic active EBV, but again, they are not typically useful for acute IM diagnosis. And finally, IgA antibodies to EBV antigens have proven useful for identifying patients with nasopharyngeal carcinoma or those at high risk for developing it.
IgA for cancer risk screening.
Exactly, highlighting their role as a screening tool in certain high-prevalence populations, allowing for earlier detection and intervention.
Beyond just looking for antibodies, what else can labs look for to pinpoint EBV infections, especially in those more serious long-term conditions or cancers where antibodies might not tell the full story?
That's where molecular tests come in.
Like looking for the virus's DNA.
Precisely. Our sources mention detecting the virus's genetic material, EBV DNA or RNA, or even its proteins, which has been incredibly valuable for definitively proving the virus's undeniable link to various cancers and chronic conditions.
How do they do that?
The polymerase chain reaction, or PCR, is a powerful molecular tool used to directly detect EBV DNA. For example, it's used to detect EBV DNA in cerebrospinal fluid for some AIDS patients who develop CNS lymphomas, helping to diagnose brain tumors.
Testing spinal fluid for brain lymphoma. Makes sense.
Yes. PCR is also absolutely crucial for monitoring EBV DNA levels in the blood of patients with lymphoproliferative disease, allowing clinicians to track disease activity and assess treatment response in real time.
So you can see if the treatment is working by measuring the virus level.
Correct. Detecting high levels of EBV DNA in blood for a few days to several weeks after IM onset can be useful if serologic studies yield equivocal or unclear results, providing a direct quantitative measure of the viral load. However, it's important to note that culturing EBV from throat washings or blood isn't generally helpful for diagnosing acute infection.
Why not just grow the virus?
Simply because the virus persists in the oropharynx and in B cells for the entire lifetime of an infected individual. So a positive culture doesn't necessarily mean acute illness. It just means the person has been infected at some point in their life.
Ah, okay. So PCR is more useful than culture for diagnosis and monitoring.
In most clinical situations, yes.
So now we have a detailed picture of classic EBV-induced infectious mononucleosis. But here's a crucial point that skilled medical professionals always consider. While about 90% of IM cases are indeed due to EBV, our sources point out that a significant 5–10% are caused by something else entirely.
Right. You always have to think about what else could be causing those symptoms.
Exactly. This is where the differential diagnosis comes in, the critical process of identifying what else it could possibly be that's mimicking those classic mono symptoms. It's about ruling out other possibilities.
What's fascinating here is that cytomegalovirus, or CMV, is by far the most common cause of heterophile negative mononucleosis.
CMV, another herpesvirus, right?
It is. This means it causes a mono-like illness, but the heterophile test for EBV, which we just discussed, comes back negative, immediately pointing to a different culprit. When we connect this to the bigger picture, CMV is another ubiquitous herpes virus, much like EBV, and it's clinically important across all age groups, from causing severe birth defects in newborns to disseminated disease in severely immunocompromised patients.
So CMV can be serious too.
It can be, especially in vulnerable populations. While it also causes a mononucleosis syndrome in healthy individuals, CMV-induced mono often presents with an older age at presentation and a longer duration of fever compared to EBV-induced IM.
Older age, longer fever, subtle clues.
Subtle but potentially helpful clinical clues for differentiation at the bedside.
This naturally leads to an important question. How does CMV differ from EBV in its epidemiology, given they both cause very similar mono-like syndromes?
Good question. Our sources explain that CMV is also found worldwide, but its prevalence can vary significantly. For instance, only about half of adults in the US and Canada are seropositive for CMV.
Only half, compared to over 90% for EBV.
Right, indicating it's less common globally than EBV. Transmission occurs perinatally, meaning around the time of birth, in early childhood, often facilitated by communal living like daycare centers, and significantly through sexual contact in late adolescence and adulthood.
So similar routes, but maybe less easily spread than EBV.
It seems so. Unlike EBV, CMV is not readily spread by casual contact. It generally requires repeated or prolonged intimate exposure. Blood transfusions containing viable leukocytes are also a known route of CMV transmission. Like EBV, once infected, an individual generally carries CMV for life, and reactivation occurs, leading to symptoms or viral shedding when T lymphocyte-mediated immunity is compromised.
Such as after transplants or with HIV.
Exactly. Organ transplantation, lymphoid cancers, HIV infection, or during critical illness in intensive care units.
Yeah.
Pathogenically, CMV also causes a vigorous T lymphocyte response during primary infection, which contributes to the mononucleosis syndrome, characterized by the appearance of atypical lymphocytes, very similar to what we see with EBV.
So the blood smear can look similar too.
It can.
Oh.
However, it's these subtle differences in clinical presentation, the specific antibody responses detected by serology, and the epidemiological patterns that ultimately help clinicians distinguish between these two common viral causes of mononucleosis syndrome, ensuring an accurate diagnosis.
Beyond CMV, our sources provide a really useful list of other conditions that can look like IM, but have key distinctions that help clinicians differentiate them.
What else is on the list?
For instance, acute HIV infection, particularly the acute seroconversion syndrome, often presents with a diffuse rash, oral or genital ulcers, and aseptic meningitis, which are not typical for mono.
Okay, HIV can mimic mono early on.
Yes. Toxoplasmosis, a parasitic infection, typically has less prominent splenomegaly and usually a history of exposure to cats or raw meat.
Got it. HHV6 infection, another human herpes virus, is generally seen in older patients than classic EBV mono.
Streptococcal pharyngitis, or strep throat, lacks splenomegaly and the profound persistent fatigue characteristic of IM.
Strep is usually more focused on the throat.
Right. Viral hepatitis, while causing liver abnormalities, has significantly higher aminotransferase levels as a primary feature, and often jaundice. Rubella features a maculopapular rash, but No splenomegaly. Lymphomas, which can also cause lymphadenopathy and fever, might have fixed non-tender lymph nodes, unlike the mobile, tender ones of mono.
That's a key difference in the lymph nodes.
And finally, certain drugs like phenytoin, carbamazepine, sulfonamides, or minocycline can also cause a mono-like syndrome at any age.
Drug reactions mimicking mono.
Exactly. Underscoring the importance of a detailed patient history and medication review. It's a true diagnostic puzzle.
Definitely requires careful consideration of all the possibilities.
Yeah.
Hashtag IA export. Treatment and prevention strategies for EBV.
So with all this complexity surrounding EBV, from its common presentation to its rare, severe manifestations, what's the game plan for treating these infections, particularly infectious mononucleosis?
How to manage it.
Yeah, and what strategies exist for prevention? It sounds like it's certainly not as simple as just prescribing an antiviral for every case.
You're right, it's not that simple. For uncomplicated IM, the therapy is primarily supportive, meaning symptomatic relief through rest, over-the-counter pain relievers, and fever reducers.
So basically rest and Tylenol or ibuprofen.
Pretty much. Crucially, our sources emphasize the absolute necessity of avoiding excessive physical activity, especially contact sports or heavy lifting, during the first month of illness.
Because of the spleen rupture risk.
Precisely. This is to reduce the very real, albeit rare, possibility of splenic rupture, which is a medical emergency often necessitating an emergency splenectomy or removal of the spleen. This is a vital piece of advice for patients to follow strictly. Glucocorticoid therapy, such as prednisone.
Steroids. Do they help?
Well, they are not indicated for uncomplicated IM because they don't shorten the course of the illness and can actually predispose patients to bacterial superinfection, making things worse.
So steroids can actually be harmful in regular mono.
In uncomplicated cases, yes. However, prednisone is used for specific, severe complications. It can be given to prevent life-threatening upper airway obstruction in patients with severe tonsillar hypertrophy, to treat autoimmune hemolytic anemia, hemophagocytic lymphohistiocytosis, or severe thrombocytopenia, and rare cases of severe malaise, very high fever, or severe central nervous system or cardiac disease.
So only for the really severe life-threatening stuff.
Exactly. It's a targeted intervention for life-threatening symptoms, not a general treatment for typical mono.
That clarifies the role of steroids significantly. What about antiviral medications like a cyclover? Does it actually make a difference for the typical course of IM, especially since it's a herpes virus, which often responds to antivirals?
This raises an important question because many might intuitively assume antivirals are key for viral infection. Our sources state unequivocally that a cyclover has had no significant clinical impact on IM in controlled trials.
No benefit from a cyclover in mono.
Not in terms of clinical symptoms or duration, and even combining it with prednisolone has shown no significant effect on symptom duration. So, for the common form of mono, it's generally not the answer. The clinical benefit simply isn't there for the vast majority of patients.
But does it work for anything EBV related?
Interestingly, yes. A cyclover is effective for treating oral hairy leukoplakia, those white lesions we discussed earlier, demonstrating its antiviral activity in a different context. But it's important to note that chronic active EBV disease itself generally doesn't respond to antiviral therapy.
So it works for the leukoplakia, but not the chronic active disease.
Correct. Which highlights that the virus behaves differently and requires different therapeutic approaches in different disease contexts, depending on whether it's latent, actively replicating, or driving malignancy.
So if a cyclover doesn't really help with regular mono, what about treatments for the much more serious EBV-associated lymphoproliferative disease, or LPD, and the other severe conditions we've discussed, which are often life-threatening?
Here, the therapeutic approach is much more aggressive and highly targeted.
What do they do for LPD?
If possible, therapy should first be directed towards reducing immunosuppression, as LPD often arises when the immune system is severely compromised, particularly in transplant patients. An antibody targeting CD20, known as rituximab, has been effective in some cases by depleting the EBV-infected B cells, which often express this marker.
Rituximab targeting the B cells.
Exactly. For stem cell transplant recipients, infusions of donor lymphocytes are often highly effective, as these new immune cells can recognize and fight the EBV-infected cells. Though it's important to note there's a risk of graft versus host disease, where the donor cells attack the recipient's tissues.
A potential complication there.
Yes. A truly cutting-edge approach involves infusions of HLA-matched EBV-specific cytotoxic T cells. These are specialized immune cells grown in the lab.
Lab-grown T cells specifically targeted at EBV.
Precisely.
Mm.
They have been used both to prevent LPD in high-risk settings and to treat the disease itself, showing remarkable promise. Other options include interferon alpha administration, conventional cytotoxic chemotherapy, and radiation therapy, especially for central nervous system lesions. What's truly fascinating here is the promise shown by infusions of autologous EBV-specific cytotoxic T lymphocytes, meaning using the patient's own modified immune cells in small studies for patients with nasopharyngeal carcinoma and Hodgkin's lymphoma.
Using the patient's own immune cells,
Yeah.
personalized therapy.
Exactly, offering a personalized cellular therapy. And for X-linked lymphoproliferative disease, treatment with antibody to CD20 has resulted in successful outcomes for what would otherwise likely be fatal acute EBV infections, representing a life-saving intervention for these vulnerable boys.
So real progress in treating these severe forms.
Definitely. Much more targeted approaches are being developed and used.
Finally, after this comprehensive dive into Epstein-Barr virus, which affects so many of us, is there a way to prevent these infections, or at least prevent infectious mononucleosis in the first place?
The prevention question, that's the big one.
It seems like such a ubiquitous virus, it's hard to imagine avoiding it entirely.
From a public health perspective, the isolation of patients with IM is actually unnecessary and impractical, as shedding of the virus is so common, even in asymptomatic individuals.
Right, if 90% are shedding it anyway.
Exactly. This leads to a profound question for the future. What about vaccines?
The vaccine hope. Is anything happening there?
Our sources highlight ongoing research in this area. A vaccine directed against the major EBV glycoprotein, a key viral component, has shown promise. It significantly reduced the frequency of infectious mononucleosis in a phase 2 trial, which is a significant step forward.
Reduced monofet.
That's good. It is promising. However, it did not affect the rate of asymptomatic infection, meaning individuals could still be infected and carry the virus, just without developing the full-blown monosymptoms.
So it prevented the illness, but not the infection itself.
Correct. Our sources confirm that additional vaccines are currently under development, highlighting ongoing global efforts to tackle this incredibly pervasive and impactful virus, aiming for broader protection, perhaps even against its more severe manifestations like the associated malignancies, which would be a monumental achievement.
A vaccine against EBV-related cancers. That would be incredible.
It would be a game changer. Hashtag tag outro.
So what does this all mean for you, the well-informed learner? We've gone far beyond the typical understanding of mono.
We certainly have.
From its subtle role in everyday asymptomatic infections to its profound, often insidious links with various cancers and rare genetic disorders, Epstein-Barr virus is a truly masterfully complex pathogen. You've now gained insight into the intricate dance between the virus and our immune system, navigated the nuances of its diagnosis through complex serologic tests, and explored the cutting-edge, targeted therapies that modern medicine employs to combat its more severe forms.
Hopefully giving you that professional level understanding.
Exactly. You're no longer just informed. You're truly equipped with the knowledge that medical professionals rely on when it comes to this fascinating and pervasive virus.
When we connect this to the bigger picture, the entire story of EBV underscores the incredible complexity and adaptability of our immune system, and the sophisticated, sometimes deceptive ways viruses can interact with it. They can, at times, turn our own defenses against us or subtly drive cellular changes towards disease.
It's a constant battle.
It is. This raises an important question for you to consider as you go about your day. As we continue to learn more about these intricate viral connections and their long-term implications, how might our approaches to disease prevention, early detection, and even personalized medicine evolve in the coming years?
A lot to think about.
It's a field that's constantly evolving.
Absolutely. Thank you for joining us on this incredible deep dive into Epstein-Barr virus. We hope you've had some major aha moments and gained a truly comprehensive understanding of a virus that impacts almost everyone on the planet. Until next time, keep digging deeper.